I actually, not that long ago, was in your guys' shoes. Fatigue.
You want to know what the mechanism was for your trauma patient?
Welcome everybody. This is the case review for February 2024. I'm Dr. Liebeck, and this particular case that we're discussing today is one that I saw as an emergency physician at one of our community sites, but it just as easily could have been an EMS presentation initially. So I hope that you find it interesting and learn a little bit from this interesting case. We have no financial disclosures. And here's how the case unfolded. We'll jump right into it. This was a 6-week-old baby girl who presented to the ED with her parents with concerns for fatigue. The baby didn't seem to be really interested or engaged in eating, seemed to be having a little bit of a hard time breathing, especially when she was bottle fed. Mind you, this is in the middle of cold and flu season, so we initially had some concerns about maybe respiratory issues. Mother further explained that the baby had only been having one wet diaper a day, and then there was a little bit of redness when she went to go clean up after a diaper change, so maybe some urinary or dehydration concerns. It wasn't clear initially. It's got a little bit more interesting when she said that they started to take a new medication, that the baby was prescribed Lasix, which we all know is not a super common medication for a 6-week-old baby to be taking, and just took their first dose yesterday. Pertinent negatives, no fever or cough. As I mentioned, this was right in the middle of cold and flu season. There was no rash or skin changes, no diarrhea. There was this little bit of redness kind of when she wiped the baby after a diaper change, but there was no blood in the stool, no seizure-like activity or abnormal neurologic movements, and there was no known trauma. A little bit of background information. We found out that this was a full-term 6-week-old baby. It was a regular vaginal delivery. She was discharged from the hospital, and then at her first pediatrician follow-up visit, the pediatrician noted a murmur and then sent the baby to get that checked out. The baby then had an echocardiogram, and on that ultrasound, the echocardiogram, they noted a large ventricular septal defect. So that is not your typical 6-week-old, right? There's a lot kind of going on with the initial gathering of information, but important stuff to understand. So same thing that you guys do in EMS, we do in the emergency department. As I'm gathering this information from the mom, we're working on our pediatric assessment triangle. I'm getting a general idea of the baby's appearance, tone, interactiveness. Is it making eye contact? Is it crying appropriately for age? How does its breathing look? Are we looking at any like nasal flaring, retractions, and the circulation in the skin, especially capillary refill at this age? But certainly if there was mottling or cyanosis, then we would be a bit more concerned, and we would be doing as we are doing things and intervening as we're getting this information. My general impression as we're talking and getting the initial information from this family is that I'm concerned about what's going on, but I don't see a lot of acute concerns with my initial assessment. A little bit of maybe retractions with the work of breathing, but overall the baby looked okay. So let's get into the details of that. I know this is a lot on one slide, but this is our physician physical exam. And there's a couple of points that I wanted to point out with this. So the baby was really calm, had okay tone, was comforted by the parents. There was a little bit of a sunken anterior fontanelle, which, as we know, can be a sign of some concern for dehydration. And listening to the baby's heart, there was a loud holosystolic murmur. I mean, this sounded like a waterfall with every every systole. So it was just a very loud, heard throughout the entire precordium murmur that you would not be able to miss. Baby had good distal pulses and pretty good cap refill. I noted it was a little sluggish in one extremity, but maybe that was just how the baby was being held. And a little bit of increased work of breathing, but not in acute respiratory distress. There was maybe some subcostal retractions, but lungs sounded pretty clear. Baby looked pretty okay otherwise. As we pull up a little bit more information in the emergency department chart, this is kind of what the echocardiogram looked like. Now, the image on the right is a representation from the internet, not the actual image, but the cardiology note is verbatim from the chart. So there's a large perimembranous ventricular septal defect. And so you can read a little bit more about that, but essentially what that is the septum that separates the ventricles has a defect or an opening in it. There's several different types of VSDs or ventricular septal defects. This is one of the more common ones, and we'll talk a bit more about that. In addition, this poor 6-week-old baby had started to show signs of failure to thrive, congestive heart failure, and again, we'll talk more about what that means and why that's important to this case. So even though baby didn't look like they were in acute respiratory distress, we were all, of course, concerned. We have this untreated congenital heart condition that we know now is a large VSD, and baby just wasn't eating right. Mom was totally accurate in her description. They tried to show me, baby tried to take the bottle, just didn't really have any interest in it. Wasn't really having difficulty breathing, but just kind of didn't really care about the bottle. And I said she hadn't eaten all day. She absolutely should be hungry. And again, had only made maybe one wet diaper throughout the entire day and was looking a little bit dehydrated. So this alone is concerning. We did a couple of basic things, got a glucose, a COVID flu RSV, which were negative, and did a chest x-ray. The chest x-ray on the right is the actual image that we had. So a little bit of enlarged heart size, and the baby had a chest x-ray initially when they were working this up. So a chest x-ray just a few days ago, even the heart size looked enlarged compared to the previous. And then there was some increased pulmonary congestion, which is kind of the fluffy parts and the parts of the lungs that should be a little bit more black. We did try to start an IV here at our non-pediatric specialized community hospital on a dehydrated 6-week-old. It did not, unfortunately, result in a successful IV, and we were really it was important for us to get a CBC to look for anemia, and I really wanted to check the kidney function and a couple of other labs as well. But those basic things were important initially as we were coordinating care with children's cardiology. So I placed a call to Children's Hospital, and we decided to transfer the baby to Children's Hospital for further evaluation and management. And this is what came of the case. So baby did pretty well. We transferred the baby, ended up getting an IV, gave some IV fluids, which is a little bit in contradiction, right? So this is the showing signs of heart failure, had just started Lasix, but was looking dehydrated, hadn't been eating, isn't having a urine output. So we're treating with IV fluids in this case, but really important for cardiology and the other specialists to manage. The baby was admitted and ended up having a VSD repair. So you can see those adorable little sternotomy wires this is a post-operative image from just 3 weeks later was the repair. Also, baby needed some more help with feed, so ended up getting G-tube. So was fed through a tube for a while to make sure that we had proper weight gain and strength to make it through all of this. Unfortunately, kiddo ended up getting a sternal wound infection and endocarditis, which is always a risk that we'll again talk about a bit later. But overall, kiddo did pretty well. Ended up leaving the hospital, is doing okay. Hopefully that was a little bit of a bump in the road, and this baby will hopefully recover and have a normal, healthy heart in the future, just after a VSD repair. So let's talk a little bit more about VSDs, ventricular septal defects. We know that it's a common congenital heart defect. Some resources say the most common. There's a spectrum of small to large, and the small ones, it sounds like oftentimes they just monitor. The smallest ones tend to self-resolve up to 90% close within the first year of life without any intervention, don't tend to cause any heart failure symptoms or anything like that. So are monitored closely, and it's really the larger ones, or the ones that are showing signs of congestive heart failure and other problems with the heart function, that need repair and further attention with our cardiology colleagues. The murmur itself is something that you may notice, like we mentioned in this child's exam. It was pretty loud and it could be heard throughout the entire precordium. The blood flows through this septal defect from one side of the ventricle to the other, typically left to right because of the pressure difference. And what we're hearing from the outside is really a turbulent flow from one ventricle to the other during systole, right, during when the ventricles squeeze. So one thing that I thought was interesting and a bit counterintuitive maybe at first is that smaller VSDs can actually be louder. So if you hear a really loud VSD, that can be that higher pressure going through a smaller opening and causing more turbulent flow. You might even be able to feel a palpable thrill over the chest, right out, over the precordium when you're touching the chest wall. But the larger ones, especially the ones that are almost the entire septum, they may not have such a loud holosystolic murmur. It's probably still noticeable. This child certainly was. You also might hear like a murmur during diastole or filling. It changes a lot of the pressures across the valves, for example, and so you may hear, yes, a holosystolic murmur, but also diastolic, kind of a rumbling, and some extra heart sounds. So it can get really involved in the flow of blood across the heart. Here's one example of what that might look like. So normal blood flow on the left. And on the right, this is showing one example of a ventricular septal defect and how the blood mixes. So the left ventricle is still pushing out oxygenated blood to the body. The right ventricle, though, because it's receiving some of the blood from the LV, is now pushing out mixed blood. So it's got higher pressures in its ventricle than it's probably used to, than it would otherwise be used to. And it's also sending out, instead of just plain deoxygenated blood that it's sending out to the lungs, it's sending out oxygenated mixed blood. And there's pressure changes that impact the valves. And the larger this is and the larger the pressure changes, the more likely the patient is to have signs of congestive heart failure and other downstream cardiac effects. So an untreated large VSD might demonstrate signs of CHF. In an infant, this might look like poor feeding, failure to thrive, difficulty breathing, fast heart rate, a large enlarged liver, which can be, again, a sign of CHF in an infant, some peripheral edema. And if this and some other cyanotic heart defects go untreated for a period of time, it can show what we call Eisenmenger's syndrome, which is cyanosis, dyspnea, syncope, and clubbing of the digits, which is demonstrated on the right. Some take-home points. VSD is a common congenital heart defect, so you probably will see a patient with this. There are size differences through different types of VSDs, small, medium, or large, with the large being the ones that likely need correction and are the most physiologically significant. They can present with heart failure symptoms before they're intervened upon, or if they're left untreated. And infants can show failure to thrive, feeding difficulties, and respiratory distress. Listening to those heart sounds matters. Your pediatric assessment triangle also matters. And a couple of other closing thoughts here, that this baby might have been easy to dismiss initially based on the low energy, dry diapers, difficulty breathing. This baby came in during cold and flu season. We see so many viral upper respiratory illnesses that this would have been easy to dismiss or gloss over. And always make sure that you listen to the parents and trust their report. And here's our references. I hope you found that case interesting and something that you could remember in the future. Thank you.